Great. Thanks, Julie. Welcome, everyone. Thank you for the opportunity to talk this evening about anesthesia for robotic surgery. What we're going to talk about are a variety of subjects, as Julie mentioned, specifically physiology and the changes during robotic surgery, the different types of surgical types that we do anesthesia for with regard to the robotic surgery, and finally, just how to have a successful robotics program. I'd like to thank everybody who's called in from around the world, and what you'll find for those of you that are experienced anesthesiologists is some of the information may be a bit elementary, and for those of you that are either non-clinical or non-anesthesiologists, some of the subject matter may seem a bit high-grade physiology-wise, but I've tried to go somewhere in between, and certainly we'll have time at the end to answer questions that might arise. So without further ado, let's go ahead and begin. So what we're going to talk about today is, number one, our Center for Advanced Robotic Surgery, what the case volume is, what our case types, what the physiology concerns are during robotic surgery, ventilation management for these complex cases, specifically the obese population, take-home messages for a successful robotics program, and then what the role is of operational excellence in the establishment of a successful robotics program. So here at Ohio State, we've done approximately 6,000 cases since 1999. That number, of course, is increasing annually. We do about 40 to 50 cases a week, and those are rate limited by the fact that we only have 5 robots. So if we had more, certainly we would do more cases. And as you might imagine, case duration varies dramatically based on surgeon expertise, the type of surgery that we're doing, the setup, the breakdown, and everything in between. We have a multitude of specialties represented here: benign GYN, benign GU, GYN-ONC, GU-ONC, colon, plastic surgery, general surgery, surgical oncology, thoracic surgery, ENT, and we've even gone so far as to do some combined ENT and neurosurgical procedures for skull-based resections. So let's suspend reality for a moment and say that we just bought a home in the Florida Everglades. And at closing, our realtor comes to us and says, "Hey, Josh, by the way, you have a baby alligator in your backyard. You can, if you choose, pay somebody to relocate that alligator, or that alligator may swim off or may not, and 5 to 7 years from now, you might be dealing with a multi-100-pound, 7-foot alligator in your backyard. What do you want to do?" Well, of course, the answer to that question is, let's relocate that baby alligator. When patients are undergoing robotic surgery, there are a lot of concerns we have, and these small problems that we note at the beginning of a case or even in the preoperative evaluation can become very, very big issues intraoperatively. And we want to deal with those when they are the proverbial baby alligator before they become big alligators during the case. But actually, the best answer is to relocate those eggs before the baby alligators even hatch. And that's what we like to do, is to deal with these concerns, these patient physiology concerns and patient-specific issues before the patient even hits the operating room. So what are some of our concerns? Of course, patient positioning, length of the procedure, which can vary anything from just a couple hours to 8 or 10 hours based on surgeon experience. Temperature control, a very long procedure in a cool room. Obviously, unlike an open procedure, we have a very narrow snapshot just with the scope in terms of, and being able to visualize blood loss can be problematic. And the question of, I have a hypotensive patient, am I dealing with simple anesthesia or insufflated abdomen, or is there occult blood loss? And if I have that, what is my management going to be for hypotension? Am I going to run fluids wide open? Am I going to start vasoactive agents? What are my choices here? What are the physiologic effects of pneumoperitoneum? And then, of course, the big one in terms of these patients with decreased compliance in the steep Trendelenburg position and in the obese population, how do we manage mechanical ventilation? So what is the cardiovascular effect of pneumoperitoneum? And the answer is, it's very complicated. So it's a phasic response. Initially, you have insufflation of the abdomen, causes compression of the inferior vena cava, increases venous return. These patients have increased preload, a very, very brief increase in blood pressure. Then they have decrease in preload from the compression of the SVC, and of the IVC. And then ultimately, however, the response is an increase in heart rate and actually an increase in mean arterial pressure during this procedure. So the question is, during this intervening period when the blood pressure is low, what are we going to do? Do we give volume resuscitation or do we start vasoactive agents? And then again, with this insufflated abdomen and decreased compliance, what is our ventilation strategy going to be? So danger, danger, Will Robinson. The pulmonary effects of pneumoperitoneum are complex. You have a systemic absorption of CO2, which causes a respiratory acidosis that's not defined by hypoventilation, okay? So we have to hyperventilate these patients, of course, to get this CO2 off. Then we have a patient now in steep Trendelenburg position, an insufflated abdomen, already poorly compliant, and now it's worsened with the insufflated abdomen. This, of course, contributes to what's important to us as anesthesiologists, a decreased FRC. So oftentimes what you'll see in these patients is the necessity to give deep recruitment maneuvers, and sometimes seated in the upright position before extubation, just to try and open up that expiratory reserve volume such that the patients don't desaturate so rapidly after extubation. And then finally, with that decreased compliance, what we find are these patients not only have elevated peak pressures, but they also have elevated plateau pressures. So no, I'm not going to ask you to go back to your first year medical school and memorize the spirometry curves, but it is important to note that what we're dealing with oftentimes with these GYN and genitourinary procedures in the Trendelenburg position is strictly a restrictive pathology. So all of our volumes decrease, and what we're concerned about mostly is that decrease in functional residual capacity, which contributes to desaturation immediately after extubation and sometimes desaturation and hypoxia in the PACU. So in order to determine what our ventilatory strategy needs to be for these patients that are in this steep T-Berg position that have decreased compliance, we need to basically understand the mechanics of mechanical ventilation and what the control panel looks like. So again, for everyone, for the anesthesiologist, this is probably pretty elementary, but for everyone else, when we talk about, we're talking about tidal volume here, respiratory rate in 60 seconds, an I to E ratio, an inspiratory to expiratory ratio, T-pause, so that means a zero flow state, which is assessment of what the plateau pressure is, PEEP, and P-max, the maximum pressure in the circuit at any one point allowed. I'd like to focus for just a moment on the I to E ratio. As I discussed before, we're talking about strictly a restrictive pathology for our patients in this T-Berg position. So unlike what we learned in medical school where we perseverated on expanding this I to E ratio in our patients that have COPD, those patients have an obstructive pathology. We want to lengthen the amount of time that they can expire. In these patients, they have no problem exhaling. The issue is difficulty in delivering inspiration given the decreased compliance. So in this case, what we oftentimes need to do is use an inverted I to E ratio to lengthen the amount of time that we deliver a breath. We can go as short as we want to on expiration because these patients, again, have not stiff lungs, but they have a restrictive pathology, so they're going to exhale very rapidly. So in these very difficult patients, your very obese patients with very, very poor compliance, you might want to consider switching from a 1-to-2 ratio, 1-to-2 I to E ratio to a 1-to-1 or even a completely inverted ratio of 2-to-1. Now the T-pause, why do we care about that? As these patients decrease as their compliance decreases, we start to see a widening gradient between peak pressure and plateau or mean pressure. And that's important to us because peak pressure in this case is what the tracheobronchial tree is seeing. What we're concerned about is what are the alveoli seeing and how can we potentially avoid barotrauma. So in these cases, oftentimes a better marker of what the potential for trauma is not peak pressures but rather plateau pressures. And then PEEP. As I've emphasized here, every patient needs to have PEEP. every single one of them. And in fact, data is emerging that indicates that you can use more of a conservative hypoventilatory strategy of 5 to 7 mLs per kilogram for your tidal volumes, as long as you're using an aggressive PEEP strategy of 6, 7, 8 centimeters of water. So we want to talk about the first and basic ventilatory strategy, and that is volume control ventilation. So with volume control ventilation, what we see is that pressure is going to build and gas flow remains constant throughout. During this state, when exhalation begins, we're going to see that both are going to come to zero with exhalation. So pressure is going to rise as flow remains constant, and obviously, if you exceed the pressure in the circuit, so the pressure max, you're going to hear an alarm. So for the surgeons on the call, when you drop that patient into that steep T-berg position, you may hear the ventilator alarming, which of course is a sign that compliance has decreased and the ventilator can no longer deliver the desired tidal volume because of exceeding the maximum pressure. The drawback for volume control ventilation, of course, is barotrauma. And the reason being, that machine is going to strive every single time to deliver the same tidal volume. So what we might see when we induce anesthesia and have a patient in the supine position for a robotic TAH-BSO, in the supine position, we may say at a tidal volume of, say, 550 and generate maximum pressures of, say, 28 centimeters water. Then when we put that patient in steep T-berg, insufflate the abdomen to deliver that same 550 cc's of tidal volume, we may now be having to generate 37 centimeters of water, 39 centimeters of water, which is going to be constant and over and over and over with each breath. So again, what we get is guaranteed tidal volume unless you're exceeding maximum pressure in the circuit, but the risk, of course, is barotrauma. On the other side of the coin, from volume control ventilation, we have pressure control ventilation. In this case here, the modulated variable is pressure of inspiration. So we use pressure to deliver a breath, and once we achieve that pressure, the pressure remains constant and flow starts to decline. We like this because during that declining flow stage, what we get is laminar flow of gases, and we actually get better airway recruitment. During general anesthesia, the apices of the lung encounter worsening dead space ventilation. So ventilation preferentially goes to the apexes of the lung, and the bases of the lung don't get as much ventilation. So we get a worsening shunt at the bases. When we utilize this strategy of pressure control ventilation, we get ventilation that is now moving from the apexes down to the bases. We get an optimization of ventilation and perfusion. So we really, really like pressure control ventilation in this case. When you compare it to volume control ventilation, we have a decreased P max, but a higher P mean to generate the same tidal volume. Now, the drawback to using pressure control ventilation is in this case, there's the distinct potential for hypoventilation. And why is that? Let's use that example again of the obese female that's going to have a TAH-BSO. We're in the supine position. We induce anesthesia. We put the endotracheal tube in, and we set a pressure of inspiration of 26. In this case, let's hypothetically say that we generate tidal volumes of 575 using that pressure of inspiration. Now we put the patient in steep Trendelenburg position, we insufflate the abdomen, and our compliance decreases dramatically. But we continue to use the same pressure of inspiration of 27. Now our tidal volumes, we note, fall from 575 to 450. In this case, we're now hypoventilating the patient. Our end-tidal CO2 would rise. So again, with pressure control ventilation, the drawback is hypoventilation. So how can we get the best of both worlds? How can we know we're going to get the same tidal volume every single time, but utilize a technique where we optimize ventilation and perfusion as we can find in pressure control ventilation? And we do that by utilizing pressure control volume guarantee mode on the ventilator. So in this case here, volume and pressure are the variables. But how does it work? I set a volume that I want to ventilate the patient with. Initially in the case, the machine is going to calculate how much pressure it takes to generate a tidal volume of, say, 550. Then it's going to switch to a pressure control mode once it's calculated the compliance and deliver that same tidal volume every single time but using a pressure control mode. When the situation changes and compliance worsens or improves, the machine will recalibrate the total system compliance and deliver a breath in a pressure control mode but with guaranteed volumes. So I get the best of both worlds. I know exactly how much tidal volume I'm giving the patient at every single time, but I'm utilizing a pressure control mode, so I'm optimizing ventilation and perfusion. So very recently, in the past year, there has been an emerging body of evidence that indicates, as an anesthesiologist, intraoperatively, we can have a profound impact on outcomes for a patient strictly based on our ventilatory strategies in the operating room. There's been a multitude of papers published within anesthesia and analgesia, and in fact, there was a great paper published in August in the New England Journal calling for a more conservative strategy for ventilation in terms of mLs per kilogram for tidal volumes. So in the past, we may have been more aggressive, utilizing, say, 8, maybe even 9 mLs per kilogram for tidal volume, and been very, very conservative with PEEP. But what this paper demonstrated, it looked at a patient population in Europe who was having abdominal surgery. Now, granted, it was open, but the principles can still be applied to our population that's having robotic surgery. They looked at a low tidal volume strategy of 6 mLs per kilogram for ideal body weight. We need to remember that, ideal body weight. Every 30 minutes, they would do a 30-30-30 technique. So that is 30 centimeter of water recruitment maneuver, held for 30 seconds, and they would do that every 30 minutes. And they would use a very aggressive or seemingly aggressive PEEP of 6 to 8 centimeters of water. And what they found with this paper is that they had decreased incidence of post-op ventilation, decreased incidence of SICU admissions, decreased incidence of pneumonia, but they also had a better outcome for non-respiratory outcomes, decreased DVTs, and a multitude of other seemingly unrelated morbidity that was reduced by using a more conservative ventilatory strategy. Now, this is very important to us because actually data has also indicated that this type of conservative approach is actually very, very positive in our female population, that women are at extremely high risk for respiratory complications in the postoperative period when using a very, very aggressive respiratory standpoint. So always remember the take-home message from this slide, even if you're not crazy about doing the recruitment maneuver, is a conservative tidal volume strategy, 6 to 8, maybe even 5 mLs per kilogram, but be aggressive with your PEEP and utilize PEEP of 6, 7, 8 centimeters of water, maybe even 10 if you need it. So I've talked for an extended period about the ventilatory strategies and the respiratory concerns, but that's not just it. There are other things that we all face when we're taking care of our robotics patients. So now what, Josh? What else do we need to do? So as we've talked about, these cases can be very, very long in our facilities where we have junior surgeons who maybe don't have as much experience with doing robotic surgery. And the learning curve, of course, can be steep. So again, we're faced with long cases, supine lithotomy in a very, very steep Trendelenburg position with those arms tucked at the side. And of course, complications may be unrelated to respiratory issues. Neuropathy is a very, very common issue. What we faced initially early in our robotics journey here at Ohio State was ocular edema and a multitude of corneal abrasions in these patients. So the postulated theory for why this occurs is that you have edematous eyes, and they're just significantly more sensitive to anything under the eyelid. In fact, we got so good of diagnosing corneal abrasions that it became routine for us to order erythromycin ointment in the PACU for these patients before they went to the floor because we had so many corneal abrasions. We've gotten better at our countermeasures for that problem, and I'll discuss those in a moment. Facial, and then by related to that, airway edema. So just as, there's no good data that says what the larynx or the laryngeal inlet looks like in these patients after surgery, but we do know that these patients' faces are quite edematous, and by extension, you can draw the conclusion that if the face is edematous, then the posterior oropharynx is going to be edematous as well. We talked about airway difficulty. And then in these patients, they're oftentimes taped in funny positions. They're cocooned in a bean bag. Cords are kinked, and we found that we had a lot of complications and difficulty in our non-invasive cuff just sort of cutting off in the middle of our procedures. So there are a lot of neuropathies related to this steep Trendelenburg position. And one of the things that the American Society of Anesthesiologists does quite well is they have a system called the closed case database, which is the ASA evaluates the 5 big malpractice firms, looks at the anesthesia-related complications, and then publishes them annually. And what they found is that 15% of all the closed case databases were related to nerve injuries, and 23% of those, so almost a quarter of those, involved the brachial plexus. In their words, the complication of head-down tilt most frequently reported is neuropathy, most common being brachial plexopathy, and causes include shoulder braces depressing the clavicles and the retroclavicular spaces, direct compression of the brachial plexus. Noted that padding of the shoulder braces does not eliminate the possibility of brachial plexus injury. So I've talked about a lot of the concerns that we have related to anesthesia for these patients for robotic surgery. And in 2006, there was a great documentary called Man on Wire about a tightrope walker from France who decided he wanted to walk between the World Trade Centers. And in fact, he did, and this is a photo from the film. And, a lot of times when we look at these patients with BMIs of greater than 50, which is not an uncommon patient for a GYN or a GU robotics surgery here at Ohio State, we think to ourselves, I'm undertaking a lot of risk to do this procedure. But the reality is, if we use a standardized technique, these patients can be taken care of very safely. And what we need to remember is that induction, maintenance, and emergence for these patients is managed very, very similar to laparoscopic procedures. Obviously, we do have a concern with post-operative opiate requirements in these patients that are obese and have high propensities for obstructive sleep apnea. So we definitely want to consider using a non-steroidal or some sort of adjunct for analgesia. Obviously, prior to incision, OG tube for gastric decompression. And in our case, as I mentioned earlier, we had this plethora of corneal abrasions early on in our robotics journey. And what we found that was utilizing ophthalmic ointment prior to placing tegaderms over the eyes and then going in the Trendelenburg position actually did improve our outcomes, and we have had a significant drop-off in the number of corneal abrasions. These patients also, of course, have a high incidence of postoperative nausea and vomiting in the PACU. Now, one thing that I'm sure most of us know on this phone call is that we have to be very, very judicious with our crystalloid administration. I've listed here not to exceed 2 liters for the case, but in my case, the nurse anesthetists that I work with, as well as the residents, know for me it's a liter of crystalloid max for the case, and beyond that, anything needs to be given via colloid. And in fact, when we do our cases, I'll place it on a pump at, say, 125 cc's an hour, just as a carrier, to ensure that for whatever reason we don't open the stopcock and then before we know it we've given 500 cc's of fluid in the first 30 minutes of the case. Now, the question I often get is, well, aren't you concerned about decreased urine output during these cases? And the answer is no, and it's for 3 reasons. Number one, in the genitourinary and GYN cases, we're in the steep Trendelenburg position. and just by positioning, it's difficult for urine output to make its way up and then down. Secondarily, we have high insufflatory pressures in the abdomen, which are actually decreasing a bit of renal blood flow, so we have a decreased glomerular filtration rate. And then finally, these patients are in pain. They're having surgery, and there's an increase in ADH, so they're going to hold on to that fluid intraoperatively. So they have 3 reasons why they might not make urine, and all I can tell you is just wait. When they go to the PACU, they will be just fine, and they will make urine. Obviously, we've talked about the Steve Trendelenburg position and patient body habitus giving us a very, very restrictive pathology, and the desired ventilatory strategy, of course, being pressure control, volume guarantee. And again, as I mentioned, the face is swollen. The assumption is the posterior oropharynx is swollen. So we have to be very, very cautious with extubation given the risk for airway edema. And similarly, these patients have decreased FRC. So the sort of gray area that we have for hypoventilation before we get to hypoxia is much, much shorter than we would have in our lay population. So for our head and neck surgeries, the anesthetic concerns, of course, relate predominantly to the type of tumor that's being resected. So, of course, if we're having a skull base or a tongue base mass, that may impact our general intubation technique. So we may need to do a fiber optic intubation. Just as we would in any other case, there's a necessity for communication with your surgeon to determine where exactly do I need to tape this tube, on the upper lip, the lower lip, to the right, to the left, etc., and what type of endotracheal tube can I use for this procedure. And then finally, obviously, as you can see from the picture to the left, to fit these arms into the patient's mouth, the neck has to be extended dramatically. So we just want to be cautious in those cases that we don't actually extubate the patient and cause a endotracheal intubation to become supraglottic. Now, we have in the past 3 years really become a center of excellence for robotic surgery in the thoracic region. And what we found in these past, say, 500 cases is that patient positioning is of utmost importance for success in these procedures. Obviously, if we're doing a lung-specific procedure, these patients are going to be in the lateral decubitus position. If we're doing a mediastinal resection, they're going to be in the supine position just with a bump. You'll note that from the top picture that these patients are really hyperflexed. And so that's to open up those ribs and really allow that surgeon and those trocars to make their way in, no problem. Early on, what you may find at your institution, and certainly we found at ours, was that the rate of conversion to thoracotomy was quite high as even 30%. So we placed epidurals in every single patient that went back for a thoracic procedure. Now we've gotten significantly better, and our conversion rate is probably less than 5%. So unless the patient has pre-existing pain issues or is a pulmonary cripple that will not tolerate opiates in the postoperative period, we do not place an epidural, and obviously in those 2 populations we do place an epidural in them preoperatively. Double lumen tube versus bronchial blocker. Everybody's got a personality, what they like to utilize. What we have found in these sorts of cases is that isolation is incredibly important, and we are unsuccessful if we utilize a bronchial blocker. So in these sorts of scenarios, in these cases, you've got to have perfect isolation, and really the best way to get that is with a double lumen tube. I mentioned earlier, in our patients that are in the Trendelenburg position, those patients have a restrictive pathology. In these patients here, of course, they have an obstructive pathology typically, and that lung is fluffy and it's never going to come down. So oftentimes what the surgeon will have to do is insufflate with CO2 to sort of compress that lung. Obviously, we're operating on the left. We need to consider decreased cardiac output in that case. And then certainly, based on that top picture, you need to remember that these patients are hyperflexed, and so there's the possibility that a left-sided double lumen tube that is placed correctly after induction of anesthesia, once you position that patient, you hyperflex the table and you sort of lengthen that trachea, that tube can very easily dislodge from a left double lumen tube to a main stem double lumen tube. Or sorry, to a main stem trachea double lumen tube.
Dr. Woodley?
Yes, ma'am.
We have a quick question to be relevant for that slide that I'm just going to go ahead and ask you.
Yes, ma'am.
The question is, when do you dose your epidural for thoracic cases?
So that's a great question. So these cases are quite long, and with these procedures, I will say the concern for blood loss is that it's going to be lots of blood loss very fast, and that is getting into the PA. And we have had actually a fair number of those instances. I've never been burned because I've started the epidural. And so what I would say for me is I don't start the epidural till the trocars start to come out, and then I'll bolus the epidural and start it at the end of the case. And the only reason is I don't want to get in a bind and be hypotensive if and when the surgeon gets into the PA and be fighting hypotension due to blood loss and hypotension due to my epidural. So I'm going to go on to the next slide. So here we have Wilford Brimley. I don't know him. I never knew him, but I can tell you just based on looks, this man had obstructive sleep apnea. And next to him we have the Wilford Brimley cat here. And I would assume this cat probably had obstructive sleep apnea too. And the point I'm trying to make here is a lot of these patients don't come in with polysomnography, which is the gold standard for obstructive sleep apnea, but we need to remember that all of these patients, specifically our obese patients with hypertension, we need to do our stop-bang evaluation, and they need to be on post-op pulse ox. So we are balancing two sides of a coin here when we do our robotics procedures. We want to do a standardized technique across procedures so that our surgeons know they can count on the same anesthetic technique every single time they have their patient taken care of. But at the same time, we also want this overlap of a personalized approach. Does this patient have PONV? Do they have right heart failure to begin with? How can we give them personalized, tailored care? And we try, if at all possible, to do a standardized approach, but leave some leeway to do a personalized technique for each patient based on their needs. So is there a role for regional anesthesia? And the answer is, other than our thoracic cases, no, we don't. And is there an indication for nitrous oxide? Absolutely not. In these cases, we want to avoid any bowel engorgement at all. We want our surgeons to have the optimum surgical field, if at all possible, so they can get in there, do their procedure quickly, and get out. So vascular access, it's a no-brainer. GYN procedures really only need one peripheral IV, but it needs to run after positioning. You need to, no one's going to fault you if you place an additional IV, and certainly if you have a discussion with the surgeon and there's concern for increased blood loss, do place another IV. Do we need an arterial line? The answer is no, unless, of course, there's patient physiology that necessitates it. So tight carotids, aortic stenosis, etc. But routinely, we do not place arterial lines in our robotic procedures. I want to be very clear and not break up here, however. Once the robot is docked, you cannot fiddle with the IVs. You cannot fiddle with the non-invasive blood pressure cuff. So it's important to remember that everything has to work and everything has to run once that patient is in the final position. So if you have an IV that's a little bit iffy, you need to place another one because you will not be able to get another IV once the robot is docked. And of course, if you utilize a beanbag, which we use here, you need to make sure that none of your lines are kinked, and of course that your blood pressure, your non-invasive blood pressure works, and do your IVs continue to work. And then finally, should I do an A-line? This is not like a typical case where you have the arms at 90 degrees and you can say, oh, you know, if we lose 400, I'm going to go ahead and place an A-line. That's not the way. If you think this patient needs an A-line, go ahead and do it because, again, you will not be able to do it once the robot is docked. Positioning. It is not the responsibility of the surgeon. It's not the responsibility of the anesthesiologist, the circulating nurse, the scrub tech, it is everyone's responsibility. And we need to pay attention particularly to the shoulders, the brachial plexus, the ulnar groove. Remember, if you're doing a lateral procedure for a GU case like a nephrectomy or a thoracic procedure, remember your axillary roll. And then finally, if you're doing a GYN or a GU case and that patient is in steep Trendelenburg, when they're in that final position, make sure you've ascertained, have they slid down at all? Is there any pressure that's being placed on them? And do we need to correct this before we initiate this case, before we start it? So I'm not asking you to just keep this patient dry as a desert, but you need to remember that the common sense of a bowel prep and, okay, they've had a bowel prep, I need to give them 2 liters immediately with induction of anesthesia does not apply to these patients. We need to minimize our fluids. Again, in this steep Trendelenburg position, excess fluid is going to worsen your facial and upper airway edema. We want to avoid that. The longer the case is, the worse it's going to be. And then finally, if you are concerned, then do a leak test at the end of the case to make sure that the airway is patent before you extubate those patients. So before you gain consent from the patient, a couple things that you want to think about. Number one, you want to inform the patient and his or her loved ones that their face is going to be swollen. You may, in fact, have a difficult time opening your eyes in the postoperative period. You may have increased PONV, and we may need to place another IV after induction. The last thing, of course, is to remember this is not like your run-of-the-mill anesthetic where you can kind of fly by the seat of your pants and extubate them maybe at the end of stage 2. You want these patients to be very awake before extubation, specifically your patients that have been in that steep T-Berg position. They have a high risk of OSA. They have decreased FRC. They now have swollen oropharynx. You want to make sure that they are awake and you're capable of extubating them safely. So discuss to them. Say, look, you may be awake when I pull that endotracheal tube. I want you to know that. And I will tell you, it's not uncommon here. And as many as say it's less than 10%, but it's not uncommon for our patients to actually go to the PACU intubated. And we extubate them, say, a half hour to 45 minutes after the case, out of concern for laryngeal edema and difficulty in reintubation. So 30 Rock, which is no longer TV anymore, has this great character starring Alec Baldwin. And in the show, he has his Lean Six Sigma black belt. So when I saw that show, I thought it was just hysterical. I didn't even know what a Lean Six Sigma black belt was. And lo and behold, now I do have my Lean Six Sigma black belt. And it's very ironic, but it's also very applicable to a very successful robotics program, because what it calls on is observation of these cases over and over and over again and utilizing a Lean and Six Sigma management technique. So looking for waste, trying to remove that waste, and from a Six Sigma standpoint, constantly trying to bring things into scopes that would get the same result every single time. We utilize all members, surgeon, anesthesiologists, nurses, and other ancillary staff to brainstorm for success. And what have we done? We've standardized work for setup for the cases itself. We 5S'd all the workspaces, so sort, straighten, shine, standardize, and sustain that work. And we tried to level load work. So if we had super high performers, we asked them to say, try and be an average performer. And if we had low performers, we asked them to come up to average performers. So basically, we knew what we were going to get every single time in every single room. We followed the Toyota production system, and then, of course, we tried to remove any waste in the system. I don't really watch NASCAR, but one of the nice things about NASCAR is the pit row. And what you see there is standardized work and people doing the same thing over and over again very, very well. And what did we find? What were some of our successes through standardized work? Number one, we grouped our lateral specific procedures in specific rooms. So if you're doing we put all of our right nephrectomies on the same day so we didn't have to move the robot. All of our right robotic lung procedures all on the same day so we didn't have to remove the robot. And again, we applied some of those techniques to other rooms, including the trauma room, to decrease our setup there. Lexus has this saying, the relentless pursuit of perfection, and we're not going to be perfect, but we can try to get there. And one of the things is we need to design this process where it's either impossible to make mistakes or it's very easy to detect mistakes. And one of the personal anecdotes from our experience is positioning patients. All three of our institutions, the Heart Hospital, the Cancer Institute, as well as the main campus, follows the same positioning protocol, and everyone knows when something is not correct. This is our value stream map of the process. I don't want you to look at the detail there, but basically I just want you to know that it is a complex process, starting from when the patient hits the surgeon's office all the way to when they leave the hospital. But in order for this to be successful, you really have to evaluate it step by step to try and accommodate the patient and offer as much value to them as possible. We did this through a define, measure, analyze, improve, and control DMAIC methodology, which has ensured us a very successful program. So what are some of the take-home messages that I'd like for you to have after this talk? So number one, for a robotics program to be successful and for the anesthesia department specifically related to robotics, we need to guarantee that we can deliver the same thing every single time. So we want a standardized process, but obviously some room to tailor it based on patient-specific needs. It has to be a team-oriented approach. So you have to have a group of people that are like-minded and really enjoy robotic surgery, and those are the people that you need to get together and put on your team to do this over and over and over again. And obviously, it's not just getting it started that's going to make this successful. You have to revisit it and say, how can we make this better? We need to generate data, we need to gather data and see how we can make it more efficient, how we can improve our outcomes, and can we pass this data on to other institutions to make our place sort of the benchmark that everybody tries to strive to become. So one last thought for all of us on this talk. Obviously, you're on this call because you're good at what you do, but you do what you do because you love what you do, and that sort of feeds upon itself. And that's what that's the way we should consider this. So I'm giving everybody an electric high five through the phone waves here. So thanks for listening, and I'll be happy to take any questions now.